And we missed all of our healthcare, I don't know what you want to call that debate, but here we are to talk about the end of the PHE. Perhaps we were talking about another emergency in healthcare on a longer term and different topic. Preparing for the end of the PHE, we're going to focus on two parts. I have a lot of slides. I'm not going to go through in depth on all of the slides, but really I want to talk about the billing, the administrative, the regulatory aspect. And then Kate is here to back me up on, I have a lot of Kate's content on what the expectations will be for our rural health clinic compliance, our emergency preparation specifically coming out of the PHE, and frankly, what it is right now, because we're seeing a lot of survey activity out there and everybody's getting hit on their emergency preparation. So we'll cover both things. So let's dig in. There we go. That's me. Hey, I am trying on a new title and I get bragging rights. And I'll just take a quick second to say, just an hour ago, the signing event for our accountable care organization, the Rural Advantage, closed. We've been approved. We have a value-based vehicle for rural health clinics, and I have a new title that I've amended. So Rural Advantage, Accountable Care, and of course, Kate Hill is with us here.
Well, first I say congratulations and a great cheer out for that, because you do so much for independent clinics. It's wonderful. Thank you.
Thank you very much. And honestly, with value-based care for all of our organizations, we hope to earn life-changing amounts of money for our practices. It's already happened. That image just came up on the PowerPoint population, and I thought it was pretty cool, so I left it. So let's talk about telehealth flexibilities. Let's talk about the flexibilities and what's going to happen to those that we've come to enjoy post PHE. I was thinking about Kate Hill was right here in lockstep with us all. Margaret, many of us were on this round robin of calls that we were going through as the public health emergency was established, and we didn't know what was happening. We didn't know what to do. And finally, we got all of these COVID flexibilities that were issued, and we got rules. The biggest ones pertain to us in rural health clinics is our telehealth services and how Medicare telehealth flexibilities pertain to rural health clinics. Of course, eligible providers, or a lot of flexibilities there with cross-state licensing. I'm not here to talk about a lot of those. I want to focus on the rural health clinic implications of the PHE and go to other places for some of the other flexibilities that affected other providers. For example, I'm not going to get in depth into the critical access hospital side of things. It's definitely outside of my wheelhouse and much too dense to talk about. That could be its whole other topic. I'm sure ICANN has that well covered anyway. So telehealth, federally qualified flexibilities, CMS, and you'll see it's linked up here, issued updates to the blanket waivers that we had all gotten used to and probably haven't looked at for a while. And again, those areas of waiver, and specifically those that have an impact on the RHC, are some of those that I already mentioned: telehealth, staffing requirements, supervisory requirements, and temporary location flexibilities that we had during the PHE. So first of all, with telehealth, probably the most consequential for many of us, biggest question, what's going to happen to G2025? For us in rural health clinics and in FQHCs, the outcome of G2025 has been a big question. We see down, this is direct language from the telehealth flexibility update, that at the end there, these flexibilities are going to terminate 151 days after the conclusion of the PHE. 151 days after the conclusion of the PHE. Excuse me for a second. G2025, the way we know it, is set to sunset, the same time. We don't know what's going to happen with G2025. The whole point of the 151-day extension is to quote unquote figure it out. Now we know that often it can take longer than that. We need to think carefully about how we want to come out on that. Many of us want just rural health clinic telehealth encounters to just be encounters just like everything else, just like the rest of the world. My only caution with that is there is a cost reporting impact. There is a cost reporting impact to that. So we don't know exactly what will happen with G2025. And I think somebody need to get everybody muted, if you could, please. I'm getting some feedback from someone's device. G2025, we don't know what's going to happen. We're going to talk about some things we do know will happen. If G2025, for a long time, we were talking about if G2025 goes away, we're back to originating site versus distant site rules, and nobody wants to do that. Nobody has any appetite for that. That's not going to be the outcome. I think we either have some long-term version of an aggregate code like G2025 is, or they just make it all encounters. I can tell you there's not a lot of appetite to just open rural health clinic telehealth encounters up and let it fly, because people are concerned, policymakers are concerned about the level of abuse that is already, people are trying to push the edges of providers sitting in urban areas and just punching the rural health clinic encounter ticket. So that's what we're trying to navigate. We will not go back to the old status quo, though, as with so many things. I don't see us going back to the originating distant site. And I think CMS is expressing that too. So we don't know what's going to happen to go to G2025. Remember, even though G2025 stops, some telehealth waivers will cease. We already have a lot of things that are cooked in to what we're doing, like behavioral health visits we're going to talk about in a second. Audio only are set to be eliminated. CMS is talking, they're going to do away with most likely audio only. NRHA, for example, is making a big push in our policy institute to, hey, whoa, be careful with rural, because we have a lot of patients that don't have anything but audio. Now, at the state level, Illinois, I know we have some folks that are from out of state here, but every state is setting different rules. Illinois cooked our long-term rules in long ago. So even if the telehealth, the public health emergency ends and G2025 goes away, look down here at bullet point 4, mental health services furnished via telecommunications are already an encounter. They're already an encounter cooked in to Medicare. Mental health visit via face-to-face encounter, furnished interactive real-time audio video is an encounter. That's now cooked in to our rules. Right now, that includes audio only visits. And when you see audio only, that's telephone only. Right now, and when they've established the behavioral health as encounters, there is an in-person visit requirement that we can make exceptions to that is also waived. I just went through those really quickly. We'll make sure you get these slides. You've already seen that material. This is the point I want you to see. The in-person visit requirement cooked into the behavioral health as an encounter. In-person visit is not going to be required for 150 days after the PHE. I'm going to go back 2 slides. So right now, the in-person, it says mental health service within 6 months prior to the telehealth visit, and an in-person visit every 12 months thereafter. Medicare said they have exceptions to that. Are patients homebound? Let's say they have big transportation security issues and just from a mental health perspective can't get out of their house. We can make exceptions. And again, that in-person visit is currently waived. These are payable as encounters. Revenue code 0900, modifier 95 if you're doing face-to-face, audio video, modifier FQ. We got it. So right now, behavioral health, forget about the public health emergency. Behavioral health, this is one of the permanent things we've seen come out of the public health emergency that now is different. We have to address clinical visits. It's the clinical visits or telephone only visits. We don't know what are going to happen in the long term with telehealth. I'm going to go through these 3 slides really quickly. You've already seen all this material. I put these up here as a reminder. Audio only, telephone only goes away. We still have virtual communication services we can bill. It's active right now. It's largely been dormant during the public health emergency because we really haven't needed them. We would bill an encounter. Why would we bill a virtual communication service? Well, these are really for not only the audio only, but the short conversations. Remember, we have a bundled code, $23 right now and 88 cents, but these are still active right now. This is outside of the public health emergency. So when our audio only goes away as a G2025, I see us utilizing Medicare. What I see Medicare, CMS coming back on the audio only and said, well, you have virtual communication services. That's where the audio only go. I have a feeling that's Charles James' crystal ball. And remember, these are in place now, regardless of what happens with the public health emergency. We have some things that I put on here because, for example, virtual communication service is supposed to be with established patients, but the established patient portion was waived for the COVID emergency. So we're going to have a lot of these services where some of the individual rules, remember, are going to go back to the way they were. Let's see that going back. See that going back to the way it was. So the reason I bring these up in the context of the end of the public health emergency is we will have some things. Now, the problem with, of course, we have a co-insurance on G2025. There is a co-insurance on G0071. We do have to be reminded of our requirements for consent. And this is another rabbit hole. Right now, during the public health emergency, consent for virtual services can be obtained under general supervision. This is the consent piece. This is where I'm fearful of some of our care management service vendors, because during the PHE, we can get some patient consents under general supervision. I didn't put this in here, but I wish I had. So remember, we have some threads to pull on some of these things once the public health emergency ends that we're going to still be finding after it does end. Now, Department of Public Aid, we could all bash them. We could all bet, whatever you want to do. They had some, this was fixed quickly, where first we got an emergency provision and next they cooked it into the rule very quickly and made it a permanent part of our encounter rate handbook that telehealth services covers any site the patient can use. And it's just wide open. This is directly out of the current electronic handbook for IDPA. Those of you listening out of state, every state's a little different. We've got a couple states that are still pretty stingy. We always have to look at Arkansas with being stingy on this stuff. And Arkansas has not yet recognized this originating site distinction, et cetera. So any of you out of state, we have to look at this, but IDPA has defined it. The originating site, we still have these definitions. I'm cooking through these pretty fast. You go through these and reference these yourselves. I want to read to you. We still have these originating site definitions, but, oh, I thought I skipped a slide. I'm sorry. I took out the billing slide. Basically, the originating site, IDPA does this the reverse. Some would say typically, right? In our context, the originating site, we get paid the encounter if our patient is being seen by a remote physician, and then the site, we, the rural health clinic, we take care of that remote physician. But basically, it says distant site provider gets paid out of the rural health clinic encounter. So it's to you to negotiate that. So all of this originating site, we are IDPA, we get a rural health clinic encounter wherever the patient is for a rural health clinic provider. It's that easy. Now, we're back to the Medicare level. We were covering telehealth flexibility. Now we're on some of the staffing flexibility. This is the language from the first waiver Medicare released on our staffing waiver. Available to operate. I have some of my panel here blocking my screen. That waiving some of the staffing requirements, specifically the 50% nurse practitioner PA requirement. Update. Yeah, look at that. That surprised me. CMS is exploring options to make the 50% rule permanently go away after the PHE. We got some political problems with that, folks. Because then if you do away with the 50% requirement, what we would be saying is we can't have a we have some political problems with that. I'm about to reverse the logic. Can you have a nurse practitioner only clinic? Can you have a doctor only clinic and it be a rural health clinic? The whole intent of the rural health clinic program was to use nurse practitioners and PAs to increase the availability of services. If we do away with that, we're kind of knocking a whole really important leg of the stool out from under our program. So CMS is exploring options to make this flexibility permanent. I can tell you places like the AMA and nurse practitioner and PA lobbies all have something to say about it. So we'll see what comes out of that. Our 50% staffing flexibility will go away. We've always had this question and this tension in our rural health clinics between what is our rural health clinic compliance requirement for an on-site provider? Does our physician have to come on site? And versus what are our supervisory requirements for meeting together with nurse practitioners, PAs supervised by physicians? So, Kate, correct me where I'm wrong, but, and this has always gotten a little confusing because of that issue, but in effect, our rural health clinic on-site physician service during the PHE could be provided via telehealth.
You are correct.
Thank you. Most of our states have allowed for nurse practitioner supervision to take place virtually or not in person or just signing off charts. Again, that piece of it is down to the states. Some of our states are still being stingy. Missouri. Some of our states have long ago opened it up where we didn't have to have on-site nurse practitioner or PA supervision.
Right. So even physically on site, many states, we don't ever care if they set foot in the building, as long as they do their duties, oversight, supervision, policy review, and consultation.
Now, this is thank you. This is one of those occasions where it's extremely helpful, frankly, to have an accreditation organization overseeing your accreditation, because the states are all over the place on this topic. And we still have the problem of one state coming in and saying one thing relative to this and another state, and even down to individual surveyors. So we have a unified response right here, because this is one of the stickier issues. What's going to happen to that quote unquote one-time physician visit to the rural health clinic annually? And you just got the answer. You just got the answer. Flexibility is currently set to return to pre-PHE rules at the end of the calendar year that the PHE ends. So not the 150 days, but again, CMS exploring options to make our current flexibilities permanent. Temporary expansion locations, you could set up across town, your building, whatever compromised. Remember, those are going to go away. Those are going to go away. So any of you,
Charles, can I pipe in there for you?
please do.
Really more of a question. So I have about 3 of those where the separation of sick and well kind of visits. And so those offices are somewhere else. If they're in a HPSA, the day it ends, like literally the next day, you can't bill that through your RHC. So then it would become that if you wanted to keep seeing patients there, it becomes a fee-for-service clinic. Is that correct?
In my view, absolutely.
Yeah, that's what I answered. And then if you want to, if it's qualifies, you could apply for a clinic there. But okay, good. I want to make sure I was given the right advice. We don't do the bill. That's why we need Charles.
Well, that's why it's a group effort.
Amen.
And
Amen.
here's what I would say to that, though. And every situation is different. Everybody's going to come up with a if then, but then, what if? If you put a mobile unit on your parking lot at the same street address, you have a different consideration.
Yes.
I think if a surveyor showed up and saw 2 separate structures on that same lot, I think we'll probably go to PHE rules before then that would state those buildings would have to be connected somehow. But that's a hairy, that's a hypothetical. Let's not do. Your temporary location flexibility is going to go away. Period. They're not looking at extending the flexibility on that.
No.
There were definitely folks pushing the edges of that. We weren't supposed to do this to establish a new rural health clinic. So if you got a temporary location that you put up because you wanted it to be a new location and you've been billing it under the other, you better get it cleaned up.
In another state, there are some people doing it to test a location for patients. Yes,
It's just like technology.
It's called.
I like to be at the
condition. We'll always push the limits, and hey, they're testing. The law said we could do it. Come on.
If the law says it would, but I never want to be the person testing it.
No, for sure.
And back to the rural health clinic, the telehealth encounter, that actually brings up a huge issue, because immediately people are wanting to have telehealth centers in one part of the state servicing other parts of the state. So how do you address that? Our standard answer is keep it in your rational service area, period. And if you do that, we can all think of exceptions to that, but if that's your answer, that's a passable answer. So temporary expansion locations, and remember on our expansion locations, if you're hoping to make that permanent, look at your HPSA. We have a whole bunch going proposed for withdrawn. The other issue, remember that we could have some discretion to waive co-insurance during the COVID-19 emergency. I don't know of a lot of people that are still waiving co-insurance. Is such a big part of our money, but part of our revenue. I'm sure this capacity will go away as soon as the PHE ends. So if you're still, we all have constant questions about our self-pay and our sliding fee scale, et cetera, how to deal with co-insurance. Just know I haven't seen anything that would extend this, but I don't see it as a huge issue. But of course, we don't know what may happen with cost sharing. One would assume cost sharing for COVID. Kate, have you heard anything about that? Will cost sharing for COVID vaccinations be implemented?
I have
would
not
be surprised at the Medicare level if it would be. I would see COVID vaccinations continuing to be handled like they have been, which is just like a flu shot.
I would hope so.
What I would anticipate. Now, we do have Kate here. We weren't sure in what degree we may talk about some of these things, but I did add some of Kate's slides because what we are, and this was the whole point, we had billing, we had compliance issues. These aren't in any order Kate would recognize, so I don't know if I kind of pulled these out of some order here, but so Kate, feel free to take over. I'm going to go, here's what we're seeing in the field. In addition to all the billing questions, surveys are resuming. We're having people get hammered on their emergency plans, namely their risk assessments. We're seeing people get hammered on their program evaluations.
I mean, I don't know what mine are at. I don't know what mine are at.
So on both of those, let's get somebody still, maybe that is, it's a background noise, pardon me. So first of all, Kate, I don't know how you're gonna do this out. Do you wanna talk about sites being prepared for another public health emergency?
Right. We found this one, this is a recommendation. This is guidance. Now, your state surveyors may survey to it and call it law. It isn't law, but it's always tough to win that argument. We don't recommend even usually having that argument if you're state surveyed. But so this is about if there's another public health emergency, and how do you work on alternate sites, alternate care sites under 1135 waiver? Well, you don't know who's going to get sick. What does it look like? I mean, that's a really challenging one to write. We have not been implementing this. I'll tell you that right now. This guidance has just been sitting there. I don't know that any state surveyor has been doing this yet. Well, the one we have, I don't know where the slides are, but is the EID. We have been asking folks to add that as a risk assessment because some people seem to think we're going to have EID. So put EID as one of your risks, and that's emerging infectious disease. So it covers a broad spectrum of things if we should have something else happen. Okay.
We are under a second public health emergency, right?
Correct.
There is a smallpox public health emergency.
No, not smallpox. No, not smallpox.
No, what? I'm sorry. What is it? There was another one. Oh, monkeypox. Excuse me, monkeypox.
Praise the Lord, no smallpox.
Yeah, much different. Pardon me. Pardon me. Make sure you get the details right. So we do have another public health emergency that's happening right now. And I know that we are seeing people get hit on their risk assessments to make sure include emergency. I mean, that's what we just went through.
Exactly right. So that's important.
Your risk assessments, of course, I just covered some of these. Make sure, going back to, of course, this has only been re-emphasized, if anything, of active shooters, natural disasters. Make sure you're getting your risk assessment updated with emerging infectious diseases, but don't forget the rest of our stuff. I looked for when emergency procedures, when all these first came out in 2015, they were active, I think, on maybe the 15th, if I recall correctly. And I was on site, and they allowed me to talk about them and put them in a presentation. So I'm going to name them by name, or else I never would. Up at Graham and Canton, I was up there doing an annual evaluation on November 16th. So they had just gone into effect. So of course, that was a big topic we were going to discuss. They were well ahead of the curve, and they had a gas explosion right downtown. Killed the young worker that was in the middle of it, wiped out every restaurant in town, and took out a block of the downtown area. And they had just activated their emergency procedures the week before.
Wow.
So we all know that all of these disasters are real. I think this Moore, Oklahoma, I'm not sure if that's the same one as Joplin. Joplin, we know, they're finding paper medical records counties away in different states. So don't forget your
So let
hazard.
me comment on tornadoes, because it's a very common subject in the Midwest. Pennsylvania, you shouldn't have it as one of your risk assessments because we have one every 30 years. Why would you practice that? So my question then is, Illinois pretty much in a tornado area?
Tornadoes should be covered here, yes.
Could be covered here. Okay, good. So my point on that was going to be, if I'm in Pennsylvania and I don't have tornadoes and it's not on my risk assessment, then I shouldn't do a tornado exercise. That's new guidance. So you pick your exercises based on what you chose as your risk assessments.
Right.
Events are, of course, events. So that's fine. But,
so exactly to that point, don't have it
assessment.
in your risk assessment if you're not going to test on it.
Right. Well, the other way around. You should put your risks that are real.
Right.
And do your test based on one of those. Yeah.
My wife is a native of Robinson, Illinois. You pull up into Robinson, Illinois, and you can't miss that there's a Marathon gas refinery there. Everybody in Marathon knows, or excuse me, everybody in Robinson knows Marathon's a huge risk. They live their whole life thinking of what happens if the plant blows up. So one would anticipate, if I was a surveyor, you can count on me asking about your Marathon plant emergency being in your risk assessment. So it's time to get back to some of our normal modes of operation in assessing other risks and having it on the risk assessment. Kate, could you talk about the volunteer usage that they're requiring now?
Yeah, when this came out initially, I called CMS and I said, wait, I'm in a lot of rural health clinics. I have yet to see a volunteer. And I said, and she said, oh yeah, right. It came over from the hospitals. Oh, well, thank you. So we don't expect you to have volunteers, but you must address it. If you think of a surveyor and a checklist, they've got to answer every block or they didn't do their job. So if they get to volunteers, if you haven't addressed it in your policy, then you're going to have a deficiency. So in your policy, you write that your Charles James Rural Health Clinic has made the decision not to utilize volunteers. If you want to have them, then you will name them, HIPAA train them, and train them on your emergency preparedness plan. It's really that simple. We all know who the volunteer is going to be. We just had an incident in Idaho. A very upset patient in the waiting room was giving the receptionist such a hard time. I mean, really angry, that another patient stepped up to help. He got a broken nose and a bloodied up face. That's the volunteer. And that's what's going to happen. Friends, family of the staff, and the owners of the clinic are going to step up and help when the time comes. So, you make the decision, but address it. Don't miss it. Okay. So that's the important piece.
If I recall correctly, I think the statement of whether or not you're using volunteers, people were getting deficiencies on that prior to the public health emergency and not really understanding why. And we just had to go and put exactly like you said, we're not using volunteers, and we would move on.
Right.
Of
Interesting.
course, you're talking to a guy whose dad was president of a medical malpractice company, whose estate spent 11 years in probate because of an outstanding liability issue happening in a clinic. So the guy getting decked in the front of the clinic, I have a question about the liability issues there, but
wow,
perhaps a different question.
Yeah, perhaps.
So
yeah,
put the statement in your
right.
emergency policies and eliminate the question. We're here to eliminate questions.
Right.
Kate, would you mind please talking about the
Not at all.
requirements for the full-scale exercises, please?
A full-scale exercise is every other year. An event qualifies as a full-scale exercise. Certainly COVID is a full-scale exercise. And then the opposite year, you can do a tabletop and sit around and talk about the creek is rising and the parking lot's flooding, whatever we're going to do, kind of thing. Always analyze. Don't ever do an event or an exercise where you didn't analyze it. We're citing that quite a bit, where they wrote it up, but then they didn't put an analysis. Okay, here's what we learned. Here's what we're going to do about it moving forward. Okay, and your exercise or event must be one, not the event. The exercise must be one of your risk assessments. That was important there. Go back to that slide because it prompted me to think of something that I didn't, a full scale exercise. Oh, so now again, this is, if you're with us, if we're with the state, I don't know, they would accept it. We have accepted COVID after action reports now in the third year, because in 2020, it was, oh my goodness, we don't have hand sanitizers, we don't have masks, we got a distance, we got to put signs on the door. It was a very different feel than in 21, where now we're talking about testing, right? And then in 22, we're immunizing. So it's a very different event. We have accepted it. I don't know why we wouldn't, but I cannot speak for the state of Illinois, just so you know.
Boy, I just, here in Illinois, and we have, so where we're using various emergencies and reactivating, there gets to be some complexity in how often you're reactivating, or if you're activating a different plan relative to weather. That after action report that Kate is talking about, and I started to mention here in Illinois, and I just heard a physician in Peoria on the radio this morning talking about the RSV flu COVID epidemic that's happening, and it's shutting down clinics.
Yeah, we've got a triple thing going on in a lot of hospitals right now. They're jammed. One thing or another. So if you Google CMSAAR, the form will pop up. This is the directions that's on the form, and it's a very wonky form. So it's just as easy to do it in a Word doc, which was the last slide was the elements that you want to include. Of course, this next page is very, very old now, but it is way back from 20. But that's
and here we go.
And then what did we need to improve? Celebrate what you did right. Write it in your report. Hey, we were instantly calling patients on the phone doing telehealth, instantly. For a group that never did telehealth, you guys did a phenomenal job of stepping up to the plate, right? And then we trained the staff, and there's a log to prove remember, the surveyor doesn't know that you trained your staff. We're not going to quiz every one of your staff. We want to see a training log, a date, some signatures, and what you discussed. Very good.
I got to repeat. There we go. So the deficiencies we're seeing, here we go.
Yeah. And I just had a call this morning with a large health system. They want to do one big a risk assessment and emergency preparedness plan. If there's nothing in that plan that calls out the clinics and their communication plan and their risks, they must have their own risk assessment. They're not going to pass survey because the clinic then doesn't have one. And so all inclusive it works, but it's really harder to do the 491.12, what is it, E, where talks about adding it all together. It's not impossible, but you've got to pay attention to the elements that you must have everything for each clinic. It is an independent, even if you're provider-based, you are an entity, let's call it an entity, billing for CMS, and you have to live by emergency preparedness. And if your hospital doesn't have it, then you're not going to pass. Okay. Add the EID, your backup. So that last picture of the tornado, remember when I started 11 years ago now, wow, in rural, the black tower that was in the back room of the clinic where the cleaning supplies were was the backup for the EMR. Do you remember that, Charles? And so that would have gone in the tornado. It would so you're not allowed to do that anymore.
You're killing me.
Why?
But because that's my worst nightmare as a guy that hosts an EHR and billing platform.
You can't do that anymore. You have to have geographically distanced. Obviously, the cloud is the safest place to put it, I think. I mean, there's issues with that too, but it's geographically distant. This one is why we have EMRs. This is the whole point, because those 400,000 records were reduced to pulp down in Louisiana.
And again, Joplin, not so far from us, had a huge case study in HIPAA.
Right.
Getting your training and testing updated, just like we've talked about, that After action report, there's the other document Kate
Yeah,
was
that's what
probably
I'm
expecting to see.
Right.
So the rest of these, I have a bunch of slides in here that are really some resources.
That is a great resource. If you're looking for an example of a tabletop exercise, it gives you the leader's notes. It gives you questions to ask. I mean, on just about any subject. They are a contractor to CMS. While we're talking about contractors, may I just throw something in here? Two states have reported to us, and there could be more, but I don't know. Florida and Texas. The federal government has hired contractors to do COVID surveys in rural health clinics. Please.
Fun.
That is very serious issue. They're looking for your Excel spreadsheet with a list of names down the left of everybody that works in the clinic. First column and who's immunized. Second column is medical exemption. Third is medical religious exemption. The next one is boosted. No, you don't have to be boosted unless Illinois requires it, and I didn't know that. But you must record who is boosted, required by the federal government. It's in the regs. So they're out there looking for this. So they're not taking this lightly. And then the next column is who's on hold. What's a wait? Usually it's a medical wait hold. And they're looking for that grid. And they're spending 3 and 4 hours in these clinics
Wow.
on a COVID survey. I can't for the life of me figure out what takes so long. But
So the point is, first of all, the COVID immunization and our staff immunization policies are not going away, correct?
no, that is written in, I don't know how they pulled it off, but that's in the law. Yep. Snuff that one out.
So providers can exempt themselves.
Correct.
We all work in some areas where there's a high level of mistrust in vaccinations, including with some of our providers. And that's fine. But just political exemption doesn't count.
Nor should it.
It's the civil rights exemption. So get a pastor to sign off, and then the medical record also has to agree. Medical director, ultimately. Somebody else in the clinic has to approve that.
Right. Charles, we're never going to question as accreditors. We're never questioning your religious exemptions, but you must have a policy to back it up.
Right.
Here's what our policy says. You can't, when on a 2-dose drug, you can't get a religion all of a sudden between the 2 doses. That ain't going to fly. All right. You could get a medical in between, something happened, but not a religion. So just make sure you're covered if it's for you, your protection. And I can't advance the slides.
Sorry about that, folks.
That's okay. That's okay.
Good. So there's, you know what? That's one thing we learned quickly in COVID as well, as dealing with Zoom issues. So there we go. That was part of the permanent record. So I included just the core elements of emergency preparation, and it's a good review for us. What should be in your emergency preparation plan. So of course, all pre-COVID, and now remember, reviewed and updated biennially. So we have had some policy changes. There's a risk assessment tool, should be linked in that document.
That's a great tool.
This is the one everybody started with back in the day.
Right.
That Googler took us right to it. Really fantastic tool, probably most widely distributed there that I've seen. Now, this does come with a lot of templated risks on it. So don't leave the templated risks in your analysis if you pull that tool.
Amen. Now, I want to bring up one other thing that we didn't mention, because it's become an issue. And that is mental telehealth, which of course you can bill for, and it's needed, much needed and necessary. But once we start rolling with mental telehealth, the numbers are astronomical.
Problematic.
And we're so far over 51% that it makes me cry, because there must have been a need in that community, a desperate need for this service.
Every community.
Well, yes, the whole US. And yet the government still thinks that mental health is not part of primary care. I happen to feel differently, but we're trying to convince the government of that, but right now, just be careful. I have a call next week. Actually, I was going to call Charles to get some suggestions with CMS on the very subject, because I think it should be visit type. So if you have this large number of mental health televisits for SUD, substance abuse disorder, those patients are seen for other things. Hopefully every one of them, because they have health issues like the rest of us. And so could we do it on not primary diagnosis, but on visit type? Because the measuring is a huge challenge right now across the country, both state and surveyors, state and accreditors. So just beware that you have to watch those numbers. And that's a billing, that's Charles' end of things, but that's going to pop in an audit that you're way over.
So to that end, go ahead and put it up.
Yep.
Here's a huge, so we know a lot of smart people in this business. One of the smartest people I know defined their behavioral health policy, just like Kate said, according to evaluation and management codes.
Yeah.
If it's an E&M code, it's not behavioral health. If it's on the QVL list, it's behavioral health. Because here's the problem you get into. Every program evaluation I've ever done has anxiety as top 3 diagnoses.
Yes.
So without your own policy, a surveyor is going to come in, oh, you don't have your own policy? Well, let's measure. And they're going to pull all your encounters with what could be considered behavioral health diagnoses. So in my view, the #1 inoculation against the problem, especially because we need to provide behavioral health services. We must provide them. And define your policy very closely so that your psychiatric nurse practitioner, who's also doing a lot of primary care, all of her visits where she defines anxiety are not behavioral health visits. And every visit that's 0900 on the QVL, those are our behavioral health services. So this is a coming issue. And my answer is always, if the resulting answer is yes, this will increase access to services, then we find a way to do it.
Right. We have to figure this out.
Especially behavioral health.
Yeah.
So those of you, here's my big kick. Behavioral health in schools.
Yep.
Behavioral health in schools. IDPA already has the school defined, or school-based programs. Loosely, they let some wiggle room in there. But in my view, go see those kids at their schools. Get consent, see the kids via telehealth, so mom and dad don't have to take a day off work to come get a doctor's note. And behavioral health, we don't have to say why.
No.
So yeah, boy, Kate, great point. Let's see. Per Illinois, PMA is medical. This is per Chaka Batley. Per Illinois Impact, a PMHNP, professional mental health, nurse practitioners, medical only, behavioral health services, LCSW, LCPC, and psychologist. Great, thank you for that. The other thing I will say, based on behavioral health, is that we've had a sea change. I thought I had a slide in here, but you know how things get out of hand. LCPCs, certified professional counselors, Medicare is going to approve them under direct supervision with LCSWs. I've gotten into major conflicts into people in the past that were wanting to bill incident 2 on an LCSW, and it was pretty loosey-goosey. And I said, no way, it literally cost me some family relationships. But now they've opened, Medicare is officially, that was in the final rule, I believe. I don't know that we have rules out yet on how that's going to affect it, but we've had this perennial LPC question. And it's about to go away at the Medicare level. It's already gone away at the IDPA level.
Let me just give kudos to Dr. I hope I'm saying it right, Perumal. Is that correct? Kudos to you, because we have to do something about, number one, the stigma, kids in homes that things are not really going very well, you know, for them, abusive homes. And
Yes.
also we've got to do something about the teen suicide business. This is nonsense. This,
Uh,
why is it, we've got to do something about that.
Mhm. Thank you.
Thank you for that comment, please.
Mhm.
Anytime I
Start
can't
step at a
get
time.
one of the kids upstairs, I get scared.
Mhm.
Yeah.
And I don't have any reason to worry. Minimize the stigma for children in school. Amen. Amen.
You know what? I'm a believer that everybody could use mental health counseling services at some point in your life. I don't care who you are. And so I wish the stigma would go away. It's really very sad.
Yes, yes.
It's
And I
like-
think, I mean, again, thank you so much. And I'm Dr. Parawan. This is my first, sort of attending this to rural. I'm a nephrologist. I work in city of Chicago, but I'll be soon joining the task force to reduce the prevention, to reduce the kidney disease in state of Illinois. So that's why I thought I'll start joining these conferences to understand beyond the city of Chicago. So thank you so much. I'm
Well,
looking
thank
forward
you.
to- yeah.
Thank you for being interested in what's happening out here, because
you
we
for
know in Illinois, we've got this kind of chasm between the two.
It's like two different states.
But
Right,
frankly-
exactly.
We have the same
Yeah.
considerations.
Yeah, yeah. And I think, it's important, like we're all in this together, right? It's not about city or rural, we're all trying to get better and help each other get better. And that's my role in the task force, to really sort of bring everyone together to look at, what's really affecting our communities as a whole.
What a wonderful way to end this. Each one of us can do something today, one thing, and to move this advance healthcare forward. Wonderful. Thank you so much.
Just
Thank
think
you.
if we get to one potential shooter.
Yeah, yeah.
I'm going to go ahead and end the
All of us
recording.
like it.